चलें ठीक है चलें जी इधर ही आ
Assalamu alaikum. My name is Manahil Malaika and I am a second year MBBS student from Shalamar Medical and Dental College. Before we proceed, I'd like the audience to kindly switch off your mobile phones to avoid any sort of disturbances. And please also note that you may write any questions you have on the question cards that have been handed over to you. And the floor for questions will be open at the end of this session. Also, please remember to fill your feedback forms in order to claim your CME credits and your certificates.
I'm Mohammad Suhaib Mubashir, and we'll both be mediating this session. The fifth session of this conference will discuss spondyloarthritis, and this session will be dedicated to Professor Dr. Nigat Mir, the grandmother of rheumatology in Pakistan, and the fifth president of Pakistan Society of Rheumatology from 2008 to 2010.
Please allow me to introduce this session's respected chairs. Professor Dr. Ahmed Saeed, who is a professor of rheumatology at Central Park Medical College, Lahore. Professor Dr. Waqar Farooqi, who is an orthopedic surgeon, currently the principal of Central Park Medical College, Lahore. Professor Dr. Afzal Hamdani, who is a professor of rheumatology at Park Red Crescent Medical and Dental College, and Dr. Aflaq Rashid, who is an associate professor of rheumatology at Sheikh Zayed Medical Complex, Lahore.
For this session, our first speaker is Professor Dr. Terence Gibson, who is currently an acute physician and consultant rheumatologist at King's College Hospital, London. Please welcome Dr. Gibson, who will be speaking on the agony of spinal pain.
Thank you for that kind introduction. Thank you for that kind introduction. And thank you very much also to the organizers and those who supported this excellent meeting for inviting me here yet again. My topic was given to me. It's not one that I would necessarily chosen myself, but here I am. It's also ironic. I'm not quite sure whether the title of agony refers to the patient or the doctor. So I'm going to talk mainly about spinal pain as it affects the low back area, because it's extremely common. And I've illustrated here an arbitrary classification, which was used by some authors quite recently in the New England Journal of Medicine to illustrate the size of the problem. It's really very common indeed. So we're referring to acute low back pain, arbitrarily patients who have a story that's less than 6 weeks, and then subacute, as you see, and chronic, more than 12 weeks. You can see it's very common. You know, the prevalence is about 12% in the population. The lifetime prevalence is about 40%. So nearly half of us will have experience of back pain or sciatica or both. Women seem to be affected more frequently than men, and those over the age of 40 are especially susceptible. So you can see that this rather authoritative article, which was published quite recently, was based on a large number of studies. It's well known that spinal pain has a huge cost and implications for society, not only in terms of individual loss of income, but for society as a whole. There's also the cost of investigation and treatment, which adds to society's costs, and in many areas of the world like this, to individual costs. And the total worldwide costs have been estimated in the billions, millions, billions of dollars. Well, I hinted at the outset that the title is somewhat ironic. Rheumatologists tend to retreat it from managing spinal pain, and I'll refer to that in a moment. Whose responsibility is it then, if it's not rheumatologists? I think it's today widely shared by numbers of practitioners in the community and in the hospital service, but rheumatologists less and less, orthopedics sometimes, physiotherapists increasingly, pain clinics have come into their own over the last several decades. And of course, certainly in the UK, it's a wonderful money earner for those outside the health service who practice heterodox medicine like chiropractors and osteopaths. In practice, then, it is a problem that's shared, willingly or not. I think it's first to recognize that back pain has many, many causes, not always associated with skeletal pathology. But here are some of the well-recognized problems encountered in ordinary clinical practice. An awareness of what back pain may represent is important in the way you approach the patient. Take a history, do some basic investigations, including blood tests and imaging. So we're all aware, I hope, that there are many identifiable causes, some of them correctable, some of them not. It is, of course, important to exclude serious pathologies like malignancy, and there's sometimes clues, and anyone with a primary carcinoma, any malignancy previously identified and presumably quiescent who presents with back pain always poses a problem with the possibility that it may have recurred or metastasized. We're all familiar with the inflammatory spinal diseases, and then if you work as an acute physician, as I do, in a busy emergency department, back pain associated with fever poses its own problems. Recognition of infection, epidural abscesses, and infective discitis, which I see from time to time in my own practice. So continuing then, other problems that may be associated, which have nothing to do with pathology of the spine. I list some other things here, some repetition over what I've just said about the importance of excluding malignancy and looking for the clues. I'm going to focus a little more, though, on the thing that makes back pain an agony for practitioners and patients, that is non-specific back pain. That is where there is no identifiable cause, having excluded as far as possible spinal pathology and extraspinal disease. A non-specific low back pain, by definition, is where you can't really identify the cause pathologically, and that constitutes 80 to 90% of all back pain. And using the same criteria that I mentioned earlier of acute, subacute, and chronic, you have some way of approaching, in a rational way, the problem. It's well known, though, that patients with low back pain often have a lot of comorbidities, and the interaction of psychological problems and social tensions unquestionably contribute especially to the chronicity of spinal pain. Nevertheless, when confronted with a patient who has a long history, more than 12 weeks of low back pain, and who has already undergone investigations which have apparently revealed no abnormality, it's still justifiable to continue a search for physical explanation. It's not only that there may well be a cause which will come to light, but it has some therapeutic value for the patient too. There's nothing worse for someone who's told there's not much more I can do. And the way to gain a patient's rapport and for you to help their understanding of their pain is to engage in some more investigations if you can justify it. Interventions then, or treatments, as recommended by the American College of Physicians, suggests that you should avoid pharmacological remedies if possible, but I think we all know from experience that that's virtually impossible. By the time you're likely to see patients with spinal pain, if you do, they will already have received simple analgesics for sure, and possibly a more sophisticated pain medicines. Interestingly, and I quote from meta-analyses which have been done on several, I'm not going to quote the literature in great detail, but I'm going to summarize it as best I can from time to time. But we know, oddly, that in controlled studies that paracetamol doesn't seem to help. Well, that's what controlled studies tell us. But non-steroidal anti-inflammatory drugs seem to be marginally better. Most studies end by saying, please avoid opiates, which means codeine and similar. And last of all, morphine and its analogues. The American College of Physicians do recommend muscle relaxants other than benzodiazepines, and I'm not quite sure what those drugs are, to be frank with you. There's weak evidence, but nevertheless some evidence that antidepressants do help, especially chronic low back pain, and obviously where there is identifiable depression or anxiety. And although the gabapentinoids are now widely used as analgesics, the evidence in countless studies indicate that they have very limited role and have none at all in back pain or sciatica. And yet, these are the drugs that we turn to. And I think this is just because we do not have substitutes for opiates. If you're going to avoid opiates, what do you use apart from non-steroidal anti-inflammatory drugs? And so the gabapentinoids are enjoying a huge popularity amongst those who treat spinal pain. Indeed, many other sorts of pain. But if you look at the controlled trials, the evidence for their being useful is non-existent. So, as we know, usually the first treatment for low back pain is an analgesic, and the evidence favors non-steroidals. Well, their use can be restricted by many things, such as renal impairment, history of peptic ulceration, and so on. Coming back to the gabapentinoids, we know that they have proven value in some patients with pain due to acknowledged neurological problems like postherpetic neuralgia and diabetic neuropathy. So there have been studies which indicate that they have value there. But when it comes to sciatica, there are several good, well-controlled studies which that they are no better than placebo. I've already indicated there may be some value for antidepressants and tricyclics, and weak evidence, actually, that a combination of a gabapentinoid and antidepressant may be helpful. Non-pharmacological interventions are really what are favored by the American College of Physicians, especially when combined with some psychological support. And that may be CBT, relaxation, or simple counseling, but other therapies known to psychologists. And patients who are given that sort of approach do seem to fare better, at least at 6 months. I'm now just going to quote some of my own experience and my modest contribution to the genre. So you have to go back some time. Why was I involved with back pain? Well, when I was first exposed to rheumatology in 1969 as a trainee, back pain was part of the role of rheumatologists. But we've gradually ceded this responsibility to many other clinicians and non-clinicians. And very few people in rheumatology now expect to see patients with back pain. One of the things that I looked at then years ago was the value of exercises. There was a time when exercises were being mooted as a very useful way of treating back pain, and indeed may well still be. And there was a question about whether one sort of exercise was better than the other. And the study here quoted was comparing it against simple heat therapy, which was provided by shortwave diathermy. Shortwave diathermy against extension and flexion X. In other words, 3 groups. And as with so many of these treatments, the majority improved, but it was improvement that didn't last. And there was no difference between any of these groups. That's characteristic of many of the studies that we've done looking at spinal pain. Another study looking at the usefulness of osteopathy using an osteopath in the community who made a lot of money out of treating patients and comparing it with shortwave diathermy that was detuned, in other words, no treatment at all, but a machine that was making a humming noise, and shortwave diathermy, which provided a bit of warmth to the patient, and then the osteopath himself in his own practice. So again, 3 groups with a control of placebo, dealing with patients who had subacute symptoms, and they all improved, and there was no difference between them. They all improved over 12 weeks. But at the end of 12 weeks, there was no difference at all between them. Then sciatica, as managed even today with interventions such as epidural injections, a study to see whether this was possible as an outpatient. Again, significant improvements in the patients given corticosteroids through into the epidural space within a few weeks, but relapse or no improvement in these patients at 6 months. All sort of disappointing studies. And then I put novel here in inverted commas because it's a study, at least the introduction to a study, using old-fashioned bone scanning, but using computer tomography to get a 3-dimensional picture. So just using bone scans, you can identify areas of metabolic activity in the skeleton, and it's particularly useful for identifying areas of metabolic activity and presumably inflammation in the posterior aspect of the spine. So usually when you see an increase in metabolic activity, there's an associated radiological MRI or CT abnormality, and it's usually degeneration. But it's only this particular investigation which will tell you whether it's actually inflamed or not. So usually coincides, as I say, with CT or X-ray changes. And it's especially useful in identifying areas of inflammation in the facetal joints. So I'm just going to quote to you and then another study that I was involved in which employed this particular modality to see whether we could identify patients whose non-specific back pain, we were told, was associated with increased metabolic activity in the facetal joints, and whether this would identify patients who would respond to targeted local corticosteroid injections. And the answer in this study was that these patients then, previously recognized as non-specific, having previously been investigated, could be helped when areas of metabolic activity in their facetal joint was identified in this way. And they could be helped by steroid injections. As with many of the studies I've quoted now, they didn't always have long-standing improvement, but people who are doctors who are engaged in spine clinics have other techniques for managing these patients. So if there's improvement with corticosteroid injections, by injecting the facetal joints, denervation offers a longer-term approach. So just to conclude, I've already indicated how common this problem is of low back pain, so common that we can consider it part of the human condition, because you'll all get it. And acute pain resolves usually, no matter what you try. And those who have more chronic pain are more problematic, unquestionably. And this, because of the associated comorbidities, their management is notoriously difficult, but not without hope. And even amongst those searching for a physical cause, with the possibility of targeted treatment, helps to establish a diagnosis, also helps patients. The emphasis on physical and psychological treatments for all spinal pain, however, seems to be preferred in the literature over pharmaceutical interventions, which is so often unhelpful. And I've already said that when it comes to analgesia, NSAIDs seem to have in trials some benefit over paracetamol. And most articles and most studies dealing with pain control in spinal pain emphasize the avoidance of opiates. Thank you very much.